Hi, this is Brian Kim. I want to share with you this case of a patient who was referred for a traumatic cataract. This patient also had about 3 clock hours of an iridodialysis. So you're going to see how I removed this traumatic cataract. There's areas of loose zonules in that area as well of the iridodialysis. I want to place iris hooks, placing a capsular retention ring, and using my minimal torsional stress technique using an injector and a Lester hook to minimize that torsional stress. And then finally using a sewing machine technique to close the iridodialysis. So you can see this is the eye. You can see the dark haze of the traumatic cataract. You can see the iridodialysis. And this is a standard Lieberman. I'm noticing the opening superiorly and inferiorly is rather limited. So I'm putting in this modified asymmetric narrow wired speculum. The narrow wire is superior. And this is a speculum that Epsilon has developed for me, and I've been testing it out. And that narrow wire speculum provides better exposure of the sclera, which is important in this situation because I'm going to be repairing that iridodialysis, which requires a peritomy and a scleral incision. Use a corneal mark, which will help me to center incise a rhexis, and then these are my incisions for the surgery, as well as incisions to place my iris hooks in order to retract that pupil. Now remember, I wanted to retract that pupil for 2 reasons: be able to take the cataract out, but also in case there is vitreous in that area, I want to be able to tamponade that vitreous away. And so by retracting that pupil, it will temporarily close that iridodialysis and minimize any vitreous prolapse. This is some intracameral epinephrine. You can see using a 2-handed technique, you can just twirl the hook down once you get it into the eye and then pull the stopper down to cinch it down. So again, placing the hook in, twirling the stopper to get it in position, and then getting it around the edge of the pupil. Just twirl your wrist, there you go, and then cinch it down. That's all you need. I could have put some trypan blue in, but I didn't, and I think that fortunately, it wasn't a big issue in this case, but I do think trypan blue might not be a bad idea. The only problem with using trypan blue in this situation, when you have a potential defect to the posterior segment, the trypan blue can get into the posterior segment and ruin your red reflex. And that's my triplanar corneal incision that I made. And then now this is my Capsulorhexis using the microforceps from Moria. Pushing some viscoelastic. I got a little bit of a bubble, so I'm going to go ahead and remove that bubble. And in these situations, when you have a little bit more of a complex cataract, it's important to just maximize your view, so don't be afraid to take those bubbles out. Go ahead and puncture the center of the capsule. Again, these forceps are sharp tip. And because it's such a low profile, these Moria Rhexis forceps are really phenomenal forceps. You have minimal OVD egress, minimal radialization forces as you're doing the rhexis. You can see the whitening of the cataract in the area of the iridodialysis there. Again, I have not encountered any vitreous thus far, but of course you're concerned about the integrity of the zonules in that area. Okay, there you go, finished off the rhexis. And this is the right-angled hydrodissection cannula. I slide it under the rhexis edge contra-incisionally, being very gentle, wiggling it a little bit, making sure I'm in the bag, getting my hydrodissection wave, decompressing the bag. I'm always mindful in these situations when you have a little bit of a capsular block and that fluid is trapped in the bag, you don't want to push too aggressively down on the lens because of the potential zonular dehiscence. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. And because of the potential zonular problems, I try to go to a low flow setting here. So I'm asking my nurse to adjust the IOP to get it to a really low flow. So we're going to go ahead and get started and just see how the chamber looks. The chamber is fairly shallow. So far, I feel like I can just handle it as it is. And rather than doing a straight chop from the beginning, I go ahead and switch to sculpt setting. You saw the IOP went to 40, which is fine. Again, this is on the slow-mo setting. And I'm just pushing and trying to cut the lens the best I can. I'm going to make a central groove and then perform a terminal chop. Yeah, so you notice I was actually in quad mode, and so I switched to sculpt mode, but as I did that, the IOP went back up. So I had to go ahead and switch. So we went back to the quad mode now. This is the terminal chop technique, placing the chopper around the contra-incisional equatorial lens material and fracturing the lens from that side. Now I have two separate pieces. Performing the cross chop, placing the chopper around the right heminucleus, pulling it centrally toward the phaco-tip and fracturing it against the phaco-tip. Using some vacuum to lift that first quadrant up out of the bag, and then emulsifying the pieces. Being very mindful not going after lens pieces with the phaco-tip. In the case of potential zonular disease, you never want to bring the phaco-tip towards the capsular bag because you can just suck up the bag if there's no zonules. Remember, the zonules are providing counterforce, pulling the capsular bag peripherally. If you have poor zonules, as you initiate vacuum, the capsular bag can come right up and then you can rupture the posterior capsule. As you can see, I'm just doing very gentle lens removal, performing multiple chops, primarily depending upon vacuum to crush and disassemble that second quadrant. I tried to make some adjustments to my setting. And then I turned the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens and pulling it towards the center, crushing it against the phaco-tip. Doing the same maneuvers very carefully and in a controlled manner, crushing the lens into smaller pieces and then emulsifying the lens piece, using some vacuum to grab the fourth quadrant, and then again, getting the chopper around the lens, crushing it into smaller pieces, and then carefully emulsifying the lens pieces. So the lens piece is kind of turning around here. Go ahead and grab and get the chopper around the lens and emulsify it. I feel like one lens piece slipped down into the left from me. And I'm like, I'm pretty sure there's a piece, a big chunk that fell back there, but I don't see it anymore. So I'm trying to retract the pupil with the chopper, looking around, and I don't really see it. I'm trying to be very careful not to initiate any vacuum in the situation that can increase risk for complications. So I go ahead and stop, but in my mind, I'm pretty sure there's a piece hiding there, and so you'll see later on how I investigate that. But I switched to the IA, again, maintaining infusion with the BSS cannula, starting subincisionally, peeling from anterior to posterior, peeling the cortex in a clean manner, and staying away from the area of the iridodialysis until the very end. So you want to make sure you clean up all the cortex in all the areas that have healthy zonules, and you're going to go after the cortex in the area of the weak zonules at the very end. And you're going to see how the capsular bag behaves in the area of iridodialysis as I try to peel the cortex in that area. So far so good. I'm able to peel the cortex successfully and effectively. And why? Because in these areas, the zonules are strong. But you see, when I go to the area of iridodialysis, as soon as I start to try to remove that cortical material, you can see the capsular bag began to collapse. And it's collapsing. Why? Because there's no opposing force from the zonules in the area of the iridodialysis. All of this kind of makes sense. And all of this makes perfect sense in the context of the trauma. I'm pulsing BSS into the subincisional area as well as the fornix in the area of the iridodialysis, and I feel like it's pretty clean. Disengaging the fluid and then pushing cohesive viscoelastic to fill the bag. And this is a capsular retention ring. I'm using the injector with the hook down. I'm hooking the left side part of the CTR, and as it internalizes, it goes in counterclockwise so that it will be delivered clockwise. And I use a Lester hook, and I'm going to use that Lester hook to hook the leading eyelet, which minimizes, it basically compresses the ring into a smaller diameter. And by compressing it smaller, it minimizes any torsional stress on the capsular bag. So here it goes. Hook the leading eyelet with the Lester, deliver the CTR into the bag. You want to make sure it's down into the bag. Deliver, I'm compressing the CTR with the Lester, and then once I get the entire CTR in, you disengage each eyelet, which goes into the bag. Fairly simple, and this is the way I do it basically for every case using a CTR. By compressing the CTR into a smaller diameter, it minimizes the stress on the zonules. Using the capsule sweep to polish underneath the rhexis edge on the left side and then the right side. And this is a single piece acrylic lens. It's going to go into the capsular bag. So far so good. I haven't really had any major issues. I have not encountered any vitreous loss. The posterior capsule is intact. I'm placing the CTR in with that technique that I just discussed, and then placing the single piece acrylic lens into the bag. And now that since I have the Lester, look, I'm going to start to look around, and lo and behold, there's that nucleus. It's actually on the left side. You can see it right there. And so since I had the Lester, I knew that I was going to get to it later. Since I had the right instrument, meaning the Lester, I was able to identify the piece of endonucleus that was hiding, and now I switched that Lester out for a viscoelastic cannula. I didn't want to use the Lester to sweep blindly because the Lester might hook something, so I switched the Lester to the cannula, which won't hook anything because it's just straight, and I place it into the AC within the pupillary center using a chopping technique to crush the lens into smaller pieces, and then quickly emulsifying the lens piece so it doesn't fly back under the iris again. So I take the chopper out, push BSS in, and then I'm getting underneath the lens, removing all the viscoelastic from within the bag, making sure both haptics are in the bag as well. You can see the cataract's all removed now, nice clean bag, and the lens is within the bag. Decompressing the chamber, and now this is some dispersive viscoelastic to fill the chamber, coat the cornea, and now we're going to go after the iridodialysis. Release the stopper, twist, and pop the iris hook off. Again, very easy to do this technique. Again, hold the proximal hook, retract the stopper, pull it down and twist it, and then you can release the iris hook from the pupil. Going to perform a peritomy. Again, remember, I have this narrow wire speculum. I have better exposure of the sclera and the conjunctiva in this area. And so using this asymmetric speculum that Epsilon developed for me, I'm able to get better superior scleral and conjunctival exposure. I'm able to perform a peritomy in the area of the iridodialysis, do a little bit of cautery as well. And then I'm going to mark 1.5 millimeters posterior to the limbus at about 2 clock hours from there to there in the area of the dialysis. Again, this is not a huge dialysis, but I wanted to show the sewing machine technique because it is a pretty elegant technique, and really for large iridodialysis, it really is a very efficient way to quickly. So I make a partial thickness groove. Again, 1.5 millimeters posterior to the limbus. I'm taking a 10-0 nylon suture and feeding it into the front end of the needle of a 23 gauge 1-inch needle. Make sure you retrieve it on the back end as well. I'm going through a paracentesis contra-incisionally and placing that 10-0 nylon suture with no needle. Again, you take off the needle from the suture and you slid that needle through the lumen of this 23 gauge straight 1-inch needle. And I passed it all the way through so I was able to retrieve it from the back end as well. And now using microforceps, I'm stabbing the peripheral iris, and then I'm going to puncture through the sclera and into the groove. So you can see the needle is going to emerge from the groove. And even though this is a blind pass, it's really fairly anterior, so the chance of you causing any peripheral damage to the retina or ciliary body or whatever is pretty low because you're, again, fairly anterior. You're just grabbing the peripheral iris root, the area that's disinserted. So you see here I'm pulling the free end of the tenonylon suture up and out, and as I withdraw the needle, I'm holding the suture with the microforceps to make sure it doesn't fall back into the eye. And then I'm just going adjacent to that spot and then piercing the peripheral iris with the needle once again, and then retrieving the suture once again with microforceps. And if I have a really large iridodialysis, I can just keep going across, grabbing the suture with the microforceps and then withdrawing the needle back into the eye, again with the sewing machine technique. But because this is a fairly small iridodialysis, what I was able to do is hold onto the suture, pull the needle out all the way, and now I just have one loop. I have two free ends. Go ahead and suture this, put some knots down, and then suture this tenonylon down. And as I suture it down, you can see the iris retracts nicely. The iridodialysis is now repaired. You can see it's a little bit dilated more in this area, but you will see that the suture is fairly loose. It's not too tight, but obviously it's tight enough that it's causing a little bit of retraction of the iris. Again, I made sure that I didn't over tighten the suture. It's very important. You don't want to over tighten the suture and potentially cheese wire through the iris tissue. And then here I'm going to turn that knot towards the sclerotomy area and just push that knot down into the sclerotomy, and then place an aidovicral suture to close the scleral groove in that area, and then using that same aidovicral to close the conjunctiva. So I go in with the INA handpiece, remove all the dispersive viscoelastic from the anterior chamber. Mind you, I did not encounter any vitreous throughout the case. The lens was nice and stable within the capsular bag. I did place a CTR because there was an area of zonular dehiscence. I used my capsular tension ring injector technique using the Lester to compress the CTR to minimize any torsional stress on the zonules. And again, I was able to perform an iridodialysis repair using a sewing machine technique. And even though it only took a few passes, you saw how efficient that was. Again, not using the needle on the suture directly, but sliding that suture into a 23 gauge needle. My friend Ashvin Agarwal did suggest using a 26 gauge 1-inch needle, but I didn't have that on site. And so the smallest thing we had was 23, and it was fairly big. So if I'm going to do a bigger iridodialysis repair, I will go with his recommendation because he's done a lot of these techniques, and I'm going to go with that 26 gauge needle, sliding that tenonylon suture through the front end of the needle and then retrieving it on the back end. And then you can go around and puncture through the peripheral iris and go through the sclerotomies multiple times, pulling each loop out. And again, that's why it's called the sewing machine technique. A very elegant technique, especially for large iridodialysis situations. And this patient has a fixed iris. You saw that I retracted the iris a little bit. I pulled the iris out a little bit. You saw that as I was doing IA, I used microforceps to pull on the pupillary edge. And I did that for two reasons. I wanted to make the pupil rounder, but also in case there was some retraction of the suture outside the sclerotomy, I wanted to be able to apply some internal tension to pull some slack out of the suture and pulling that suture inside the eye, which is going to be, of course, safer to have more suture, redundant suture in the eye than outside the eye. So this patient, he had immediate improved vision and noticed significant improvement of his glare, again, because we repaired the iridodialysis using the sewing machine technique. So I hope this was helpful to you, and I thank you for your attention.